that we're going to do later today. So folks, please, if you can, join us again. We're going to be talking about the antibody treatments tonight and how to access that for your patients. And that starts at 6, and you've received information about that already. Today, we're going to get right to it because there are just so many questions, and we have 2 very familiar speakers that you all know and have been in the media quite a bit. Lauren Myers, has been leading the pandemic consortium. I probably didn't get that name right, but basically that's what it is, and been in the media all over the place. Parker Hudson, IDDoc, and hospitalist internist, who was on the governor's panel for a while until the governor didn't need one anymore. Has been here also several times before. These guys are great speakers. You all asked for us to bring them back, and we're really pleased to do that. Just to remind folks, there's CME available. In the chat, you'll see a link for that CME. And again, if you've got questions during this, we've got a bunch of questions that we received before. If you've got questions during it, use the Q&A feature at the bottom of your screen. So with that, I will hand it over to you all.
Great. I believe I'm up first. I'm going to share my screen. Thank you for the introduction, Clay. And I've said this every time I've come and spoken to you, but I mean it today more than ever. Thank all of you who are on the front lines, keeping us all healthy and safe at a point in time where, I think our healthcare systems are more overwhelmed than probably any of you have ever experienced it in your careers. So thank you all so much. So let me start sharing my slides. Okay, so we have a lot of material to cover. I know that Parker also has a lot of slides. I'm going to give sort of a high-level perspective of sort of the situation and near-term projections in Austin, in Travis County, and then Parker's going to dive in a little bit deeper into what we understand now about the Delta variant. So my outline is I'm going to provide a situation update, say a few words about the return to school, K-12 and UT, and then spend a few minutes talking about what might be in store with the next influenza season. So these are a couple of graphs showing what has happened with the variants in Texas over the last few months, actually since the beginning of the year. The 2 graphs are basically showing the same thing. The top is just the raw number of sequences that were characterized as each type of variant. Black is alpha, orange is delta, blue is gamma, and green is other. You think of that as wild type. And the bottom is just showing the same data in terms of proportions of sequence sampled, specimens sequenced. And so what you can see is that Delta has recently grown to constitute about 100% of specimen sequence. So most infections that are occurring today around Texas are caused by the Delta variant. This is an estimate of the proportion of the population in Travis County in different age groups that have had at least 1 dose of vaccine and are fully vaccinated. And you can see that, well, the 0 to 11-year-olds, of course, don't have access to vaccines. And there's a pretty pronounced age trend where we have very high levels of uptake in people over age 65. And those proportions decline as you get younger and younger, with an overall uptake of about 56% of people in Travis County having been fully vaccinated, 65% having at least 1 dose. So as you are probably all aware, we are sort of in a very dire situation in Austin. We very quickly saw hospitalizations increase, hospital admissions, which is what's tracked on our key indicators dashboard, increase since I guess it was early July. And we've been in the red stage 5 zone for a couple of weeks now. And this is actually yesterday's dashboard. Today's dashboard has an even higher number of COVID patients in the ICUs. This dashboard and the policy triggers to change from green to blue to yellow to orange to red was designed to try to ensure that we never exceeded 200 ICUs, COVID ICU patients on any one day. And unfortunately, we're at that sort of breaking point where we now have more than that number in our ICUs. We do see, this recent slowing, maybe even a downturn, but at least a slowing in the rate at which the admissions are increasing is a positive sign that some of the public health messaging, some of the changes in staging is having the desired effect of changing behavior and slowing transmission. And we just hope that that continues. This is a screenshot of from our dashboard, which projects we update it most days, projects the number of COVID patients requiring ICU care, number of COVID patients in hospitals, 3 to 4 weeks into the future. And so you see we're at this very uncertain moment. These little gray lines on the far right of your screen are equally probable future trajectories. The median trajectory shows the ICUs continuing to increase, but this does not account for possible behavior change that might slow things even further. And you can see there are equally probable trajectories that show us very quickly decreasing. So we're at a very, very uncertain moment given the data that we can see. On the same dashboard, we also report the effective reproduction number. It's our estimate of the effective reproduction number that we make based on the local hospitalization data and also local mobility data. And I won't go through the whole story, but early on, prior to any intervention, with the wild type variant, we estimate a reproduction number somewhere around 3 or maybe even a little bit higher. It has ebbed and flowed. This represents that first summer surge in 2020. This sort of prolonged period where the reproduction number was above 1 is what led to our winter surge that peaked in January of 2021. And you see this increase that's happened over the last month where we had reproduction number well above 1 that has driven the current surge. Looking a little bit more closely at who's in our hospitals, these are COVID hospitalizations. These are actually admissions by age, and they're stacked in order of age, where this red and pink are the youngest age groups. And you can see there seems to be a recent increase in individuals under age 17 that have been admitted to hospitals. The darker green is 17 to 49, the light green is 50 to 64, and the blue is the 65 and older. And you can see that we have, hopefully because of the vaccines, high level of vaccine uptake in people 65 and older, we see that there's a lesser proportion of people in hospitals that are in that older age group compared to the earlier surges. This is looking at in-hospital mortality for COVID by age. This is a 7-day rolling average of people who've died in hospitals from COVID throughout the pandemic. I'm just showing you 2 different age groups. This is the 65 and older, and this is the 17 to 49-year-olds. And the reason that I'm showing this is to show this recent concerning increase. This is just raw numbers of deaths in this age group. This solid red line here and the solid red line here represent the maximum rolling average, 7-day average of deaths that we've seen throughout the pandemic. And this is double the maximum that we've seen at any point in time. And so our recent trends are a bit alarming in this age group. And this is looking at who has been hospitalized over the last little over a month based on vaccine status. And so these are raw numbers of hospital admissions. Green is unknown vaccine status. Blue is not vaccinated. Orange is partially vaccinated, and the black along the bottom is fully vaccinated. So you can see there's a steady trickle of people coming into our hospitals, even coming into our ICUs and requiring ventilation in this vaccinated or partially vaccinated class. This is the exact same data, but shown as a proportion of admitted patients. And I think as of yesterday, there were about, 12% of our hospitalized COVID patients had already been vaccinated, fully vaccinated. And I believe about 9% of our ICU patients had been vaccinated across area hospitals. This is a screenshot from another one of our dashboards. This is the Austin risk mapping dashboard. The map I'm showing you in the upper left is broken down into Austin's zip codes, Travis County zip codes, and it's colored according to the CDC Social Vulnerability Index, which is a composite score based on a bunch of different census and social variables that has been shown to correlate to resilience to all sorts of stressors, natural disasters, outbreaks, economic stressors, et cetera. And so you see this sort of very strong east-west divide that you're probably familiar with, where our east zip codes tend to be much more vulnerable than our west zip codes. Many of these zip codes are majority Latino. Many of these zip codes over here on the west are majority white. And so now we're going to look at several different sort of COVID variables, and you can compare them to vulnerability up on the upper left. So the map on the left is the hospitalizations, the new hospitalizations that have occurred over the last 4 weeks. And you can see that there's a heavy sort of east bias again, with individuals living in our eastern zip codes more likely to have been hospitalized for COVID over the last month. These are cumulative in-hospital deaths per 100,000 from the entire pandemic. And you can see that the burden has been felt much more heavily on the east side of the city. And this is vaccine coverage. This is the proportion of individuals in each zip code that has received at least 1 dose of vaccine. And you can see the pinker colors are the lower coverage, the bluer colors are the higher coverage. So there's strong correlations between social vulnerability, COVID burden throughout the pandemic, and lack of access or a low uptake of vaccines. And all of these graphs are things, and maps are things that we update at least on a weekly basis and are available on our website. This is another graph from that same risk mapping dashboard. In this case, we've divided the counties into 4 different quartiles based on their SVI. So the darkest blue are our most vulnerable zip codes, most vulnerable 25% of our population, all the way up to our least vulnerable 25% of the population. And then this graph shows the vaccine coverage for each of these quartiles. And you can see that our most vulnerable 25% of our population has far lower coverage than our least vulnerable, and has sort of lagged that uptake throughout the vaccination period. So let me just talk for a minute about return to school. And I know this will be the subject of Q&A as well. We don't really have a crystal ball for what's going to happen. It is very possible, very plausible that as children, young adults gather in large groups for the first time with or without face masks, that will amplify transmission and exacerbate the current situation. We have a dashboard that we've maintained for most of the pandemic that provides county level estimates of the likelihood that 1 or more students would show up infected to a school campus. And so and you can zoom into the different states, but in what I've shown in the screenshot is that as of yesterday, we estimated that in a school of 500, so that's this little slider down here, in a school of 500 students, we would estimate that six students would show up infected tomorrow for school, just based on this is driven by New York Times data on the number of reported cases in the county. We've also done some analysis that is provided in a report that we put online last week. This was analysis that was requested by the University of Texas to help them anticipate what might happen when students return to UT and help them make decisions about how to prepare for and mitigate risks on campus. This is just one of several graphs, but in this report, we estimate the number of students that will return to UT vaccinated, and we estimate it'll be somewhere between 60 and 80%, which is what we show here in these 2 graphs. We estimate the number of students that are likely to return from other cities infected when they come back to campus. And then we make projections based on the patterns that we saw last year, the reproduction number that we've been estimating recently in Austin. And one of the real foci of this analysis is what is the risk depending on what proportion of students are vaccinated, and how can we use proactive testing, asymptomatic testing, regular testing of students, faculty on a weekly or even twice weekly basis to identify silent cases, and isolate them and prevent transmission. And these series of lines correspond to different frequencies of proactive testing, from testing everybody once a week, symptoms or not, once every single day, symptoms or not, to only testing symptomatic people. And in the same report, we do some cost analyses around how much it will cost UT to implement testing, but also deal with the costs associated with not controlling the spread of the virus on campus. So finally, let me say a few words about seasonal influenza and what might happen if and when we have both COVID and seasonal influenza circulating this winter. So this is a time series estimate of influenza activity in the United States from 1998 through 2019. And you see what you're probably very familiar with, which is these sort of seasonal, very stereotypical epidemics that sweep through Texas, through Austin, through the country. They typically peak sometime between December and February, or can even be March, December and March. And we experience sometimes large flu seasons, sometimes small flu seasons, and you can see that difference through time. That red peak in the middle was the 2009 H1N1 pandemic, which emerged in May of 2009 and then peaked early in October. And the orange peak on the far right was our most severe influenza season on recent record, 2019 through 2017, 2018. And where an estimated over 60,000 people died in the US that year. And just for comparison, we estimate that in 2020, over 550,000 people died from COVID. As you know, we have the influenza vaccine is one of the key weapons in our arsenal, one of the only things we really do on a sort of societal basis to mitigate flu. But it's not a silver bullet. Its effectiveness varies from year to year, depending on a lot of factors, but also depending quite a bit on the antigenic drift, the evolution of the flu virus, that can lead to a mismatch. We typically have to determine which viruses we're going to put in the vaccine 6 to 9 months before we actually deliver the vaccines. And you can see, looking back in time, that vaccine effectiveness has been as low as 10% in the 2004-05 season and as high as 60%. That looks like that was estimated in 2010, 2011. We also have seen pretty flat uptake in the flu vaccine. The green is adults, the blue is children, sort of hovering around 50 to 60% for children, hovering between sort of 40 and 50% for adults. But we do see sort of a promising trend in increasing uptake in adults over the last 4 years that will hopefully continue into the future, especially with the focus on vaccines for COVID. So what else is in our arsenal for influenza? Well, hygiene, hand washing. For a long time, we have used antivirals, particularly Tamiflu, to treat patients to prevent severe outcomes and shorten the duration of symptoms. But recently, we have a new addition, which is the recently approved Baloxavir antiviral, and clinical trials suggest that if administered shortly after symptom onset, Baloxavir can much more rapidly decrease viral load, arrest viral replication within people, and thereby even further shorten the duration of symptoms compared to Tamiflu, but also shorten the infectious period. And so unlike other antiviral drugs, Baloxavir is one of the first that can actually potentially be used on a population scale to prevent transmission and slow spread. And the paper that I have here on the bottom of my screen is a study that we did prior to the COVID pandemic, looking at the utility of ramping up rapid early treatment with Baloxavir in future influenza epidemics and pandemics. But we now have some new weapons in our arsenal for fighting flu that we have learned through our experience with COVID. First and foremost, face masks and other social distancing measures that we adopted throughout what would have been the 2020-2021 flu season, which essentially completely quashed influenza. So this is a graph. You may have seen versions of this. This is from Scientific American, looking at what happened during the 2020 flu season in the Southern Hemisphere. That's that orange line, which is completely flat as compared to prior flu seasons. And the patterns look identical in the Northern Hemisphere. So those very extreme social distancing, non-pharmaceutical interventions were highly effective at preventing flu transmission. In addition, we have really sort of normalized the use of testing symptomatic and even asymptomatic individuals, followed by isolation of positive cases, as a way to prevent transmission and protect communities. The paper I show you on the bottom right is a cost effectiveness study that we did about a year ago, showing that depending on the rate of transmission of COVID, daily or weekly or biweekly testing can be a cost effective way to dramatically slow transmission, save lives. I think it's an open question, interesting question, whether we can use testing for influenza in a similar way to identify asymptomatic cases to prevent transmission, as we are doing with COVID. So given all these things, what can we expect? I think there's a huge amount of uncertainty as to whether we are going to have a big, a small, an early, a late flu season. There have been a lot of discussion, a lot of people hypothesizing that we're in for a worse influenza season than usual because we have a higher level of susceptibility in our population at the outset than in a typical flu season, because we didn't have flu last year, because we didn't have a wave of transmission that led to a large fraction of our population immunized. So more susceptibility, more flu. However, that's not a sure thing. As you look back at this and just squint at this time series, you can see here's an example of a pretty small flu season that was followed by another pretty small flu season. And our 2017-18 flu season, which is one of the biggest on record, was preceded by a pretty moderate flu season. So it's not a guarantee that just because you have a small or no flu season that you're going to have a large flu season the next year. I think also sort of in the more pessimistic side of things, kids are going back to school in a more sort of normal way than we did last year, with or without face masks. In general, during flu seasons, children are sort of that leading wave of transmission. They spread it in schools, they bring it home to their families and to their communities. And so with the return to school, much larger numbers of kids, lower precautions in place, that sets us up for maybe a more typical emergence of influenza this year. But in the sort of more optimistic camp, there have been reports that we are seeing lower levels of genetic diversity among the flu viruses that are circulating this fall compared to last fall. And you can see this is a phylogenetic tree showing the evolution and diversity of flu specimens that have been sequenced. And you sort of see this cloud over, it's hard to see, of a bunch of different colors around 2020, representing the typical high amount of genetic diversity that was circulating around the globe about a year and a half ago. And now you see a much sort of slimmer a set of viruses, just the yellows and greens, suggesting that maybe we're more likely to have a good vaccine match because the virus has not evolved quite so much in the last 18 months. We also might have higher vaccination rates than ever, given the recent trends and the fact that a lot of people will also are paying a lot of attention to vaccines because of COVID. And then, as I mentioned earlier, we have these new weapons in our arsenal: face masks, social distancing, testing, and other non-pharmaceutical interventions that we may be deploying for COVID, or just may have become normalized as something we might think of doing for influenza and other respiratory viruses. So with that, I just want to acknowledge that the dashboards, the work, the projections that I share today was the work of dozens of people who've been collaborating since the beginning of the pandemic at UT's COVID-19 Modeling Consortium. Thank you so much.
Thank you, Lauren. Really, really interesting and great to hear us start talking about flu projections as well. Lots of interest in the Q&A with some questions. Hopefully you can answer there. I'm going to get started sharing my screen. I also have a lot to cover. All right. So thank you all for having me back. It has been a while to discuss the Delta variant because Delta is different. So I have no disclosures and we submitted the learning objectives before. I will say I'm going to move quite quickly, hopefully not uncomfortably quickly, but we can make the slides available. And I took the pre-questions people submitted. I've tried to answer them throughout, but hopefully there will be time towards the end to answer questions. So as Lauren already showed, Delta has vanquished all other lineages and variants of concern in the United States. We know that epidemiologically. The question is why biologically? And I would say for that, we're not exactly sure. It wasn't predicted based on the mutations to be particularly bad, but some combination of a mutation in the cleavage site and then two mutations in the receptor binding motif of the receptor binding domain where it attaches to the ACE2 receptor seem to be, plus the D14G, which all of these variants have, seems to be a magic combination. So Delta, the symptoms of Delta are not particularly different. It's SARS-CoV-2 that causes COVID. In the unvaccinated, it's really the same symptoms we've always been expecting. I think the important thing here as vaccinations go up is to recognize that vaccination does cause milder symptoms. So you see less of the fever, cough, shortness of breath, and you see more of the upper respiratory symptoms, which we'll talk about, which is to be expected. There's probably more asymptomatic disease with vaccination, and then as expected, you recover quickly, more quickly based on your symptoms and sort of the number of days that you're out. And so the bottom line is that vaccinations are doing a great job of moving us from COVID being a severe life-threatening lower respiratory tract infection to becoming an upper respiratory infection. And this is the path to having an endemic virus that is mostly another one of the coronaviruses that causes colds. So what do we know about the viral loads? So there's some scientists on the call, I'm sure, who will criticize the use of viral loads for cycle thresholds. They are different. Cycle thresholds are in PCR, and it's basically how many cycles in which it turns positive, which when you look aggregate across this, I think, provides some information about how much virus is there on any specific individual sample. May not be that useful, but I think we all agree the red dots of Delta are higher in viral load, lower in cycle threshold than previous variants. And that's one of the things that's been described biologically, is that the viral loads are higher. Interestingly, I'll come back to from days of illness, on day 10, when we end isolation, the viral loads are also higher. But now let's look at vaccinated versus unvaccinated. These are data from Singapore, which had Delta arrive earlier. And this is admitted data, but importantly, in Singapore at this time, they were admitting all people who tested positive as an isolation and monitoring strategy. So this isn't just admitted because of severe COVID. And what we see in the first few days is viral loads that are almost undistinguishable between vaccinated and unvaccinated. And then, as expected, your immune system really kicks in and you have faster viral decay in vaccines. And I think one of the really remaining important questions now with Delta is isolation time of 10 days appropriate, especially for unvaccinated? Additional studies here in Wisconsin showed, and what we've known previously is somewhere around 25 on these PCR studies corresponds to viable and possibly infectious virus. So this is, I think, a very important question going forward. So we're going to shift and talk about vaccines. Really nice summary of different factors that contribute to vaccine effectiveness. We know that there are different parts of our patients or ourselves as individuals that you make a better response if you've had a previous infection, and you don't if you're immunocompromised, have underlying health conditions, or older age. And then we're going to focus on some of these immune factors on vaccine effectiveness as far as high antibody titers, mostly today, and then talk some about which vaccines, number of doses, and timing, as those are becoming, that's the area of controversy now after the White House brief yesterday. So a lot's happened in this space in the last 2 weeks. I say giving a talk on the Delta variant is hard because the last 2 times I've done it, and even today, data's come out this morning, or there's probably something coming out right now that probably makes this talk already partially out of date. But this is an important study from Nature Medicine late this summer a very nice modeling study of the fact that neutralizing antibody levels are a good immune correlate of protection from symptomatic SARS-CoV-2 infection. So what you're seeing here is these are the randomized clinical trial data that prove the vaccines worked. And then they compared it to convalescent plasma, so people who recovered from natural infection, and they standardized it to that. So that would be considered 1. And this is your protection from a symptomatic COVID-2 infection. And what we see here is that the higher the amount of neutralizing antibody, the more protected you are from getting symptomatic infection. And here we notice that the Pfizer, BioNTech, and then the Moderna does give slightly higher antibody levels. At that point, though, both of them, as you know from the original randomized trials, were very effective. Again, this is all pre-Delta. This is all pre-Delta data, okay? And pre-Delta, they then modeled when we might need a booster based on waning effectiveness to infection. And depending on the initial efficacy and what effectiveness you were looking for, it looked like it would be, in 6 months to a year. And now with Delta, we know that the antibodies are not quite as protective, and so that would reduce this time from this previous model. But what we absolutely know about vaccinations is that the vaccinations work to protect you from severe disease and death. The vaccines are the key to decoupling cases from deaths, even for Delta. Here you have cases and here you have deaths. This is the pattern of a URI for the most part for many of the thousands of people who were tested positive for COVID in the last few months in the UK with the Delta variant. And the fact that unlike all previous peaks, they do not have peaks of death because of the high vaccination rates there. So the vaccines work for severe disease, absolutely. Then came the MMWR, the CDC's big announcement. Actually, they announced it before they released the data, which caused this confusing public health message. The vaccines weren't working because there's this, because the viral load, or we already talked about, the cycle threshold is the same between vaccinated and unvaccinated, and then we added back masks and these other interventions. And I think that was probably the wrong message. I think they worked hard to clarify that message, but people heard, I think, the wrong message. I think the truth here is that the vaccines are great. This is a huge outbreak with 0 deaths. And we knew all along that vaccines are not sterilizing immunity, and we really lost sight of the 3 C's, which we still need because vaccines are not complete for transmission. So this is the future state where people gather and there are cases that spread of SARS-CoV-2, but our hospitals and ICUs are not overwhelmed and people aren't dying. That is the URI endemic phenomenon. And so when you read more carefully, the people with COVID were more likely to attend the densely packed indoor-outdoor events that included bars, restaurants, guest houses, and rental homes. This isn't Delta. Delta is more contagious. This is just what we know about SARS-CoV-2 and COVID. And so the 3 C's really matter. And again, even more than masking, right? It's about the closed spaces, the crowded spaces, and having close contact. So, imagine the opposite, where, there wasn't 70% vaccination in this group and what that might have looked like. So if you look at a more careful approach, like in Singapore's contact tracing, then the Barnstable just, here's this data. This is the Singapore, their publication of a cluster outbreak from a Singapore market and food court. And you can see here that people are getting infected who are fully vaccinated in green versus partially vaccinated in yellow versus not vaccinated in gray. And if you flip the colors and highlight who's asymptomatic, you can see clearly that asymptomatic vaccinated people are part of these transmission chains. Vaccines certainly prevent disease. The best data even came out. There's another paper out this morning showing that vaccinations reduce transmission probably by about 50% by themselves, not just based on viral load, which was the message people heard from the CDC report, because of all the other factors, the symptoms, the viral decay, which I already showed you. And so there are other things besides just the PCR result that affect actual transmission in real world settings. So the 3 C's and masking and then testing, I think, are going to continue to be the keys for transmission. I have to highlight this because you're going to see more and more charts like this because they grab the news headlines. If there's increasing numbers of people that are hospitalized, the vaccinated people who are hospitalized, and it's important for us to, it's probably beyond this talk, but to think about the limitations of the observation data and where there could be bias in this reporting, because in general this reflects increasing in the vaccine coverage. So there's more older adults who are also more likely to be hospitalized, either with, but also still more likely to be hospitalized from COVID. So this alone is not a sign that there's a waning vaccine effectiveness. So please think through when you read these headlines, what's the denominator of the percent that people are showing? So when you look more carefully, this is the Mayo study. Dr. Fauci also cited this in the White House brief. This is going a little more detail. This is up through the onset of Delta over the last 9 months, and you have equal numbers of people who got Moderna, Pfizer, and are unvaccinated. And importantly, now these people are matched based on their age, one of the factors that would drive vaccine effectiveness and for infection and hospitalization. Also, history of whether they had prior SARS-CoV-2, and also followed for the same amount of time from their date of full vaccination. So what you see for infection, the vaccines are working, okay? The vaccines work. No question about that. I think anybody can interpret that from this picture of COVID incidence. Now, this though is starting to be, I think where some of the concern comes in, that the Pfizer data, even in people matched, the same number of people matched by age, matched by duration of vaccination, do look like they're breaking through more. And when they flip that around, and you look at both infection and hospitalization as vaccine effectiveness rather than just incidence, this is what the White House was pointing to of a possible decrease in effectiveness. Certainly, I think everybody agrees there's decreased effectiveness based on either Delta or waning immunity or both. In this sample, since Delta, it was really in this last month when Delta became the majority of isolates here. And then the significance of this, I think, for hospitalization remains to be seen. On the other hand, this data is complicated. This is MMWR data from yesterday from New York. And when you really get into it, this stuff is really complicated. So when you look at all adults down here, and you look at when you look at incidences here, and then you look at estimated vaccine effectiveness for infection, this isn't for hospitalization, you see this is what they cited, that it maybe dropped from 90 to towards 80%. When you divide this up, we actually see that there's not a lot of evidence of waning effectiveness, even in the older age group in New York here, and that a lot of this is actually driven by the younger group who was vaccinated later, who's definitely not a result of waning immunity. And this is likely behavioral, that there are differences in this observational data. These people, people who are vaccinated may be testing more, and they also in finding more asymptomatic infections, and they also may be going out and living their lives because that's the whole reason they got the vaccine. But I think there are behavioral factors that are driving this. So overall, I think this is very reassuring data. And of course, for severe infection, hospitalization, and death, of course, that data is robust. So vaccine effectiveness against infection, again, another cohort. This is in healthcare workers, though. So this is also a bit more concerning. Very crude way to display the data. I would like to see a little bit more. But again, this is a cohort where people are unvaccinated and vaccinated on the front lines, and they're testing every week. So testing bias shouldn't really affect this. And this is concerning to me as a healthcare worker for our patients really, as evidenced by this outbreak from Finland, which hasn't been reported, hasn't gotten too much attention. But 9 days after a patient tested positive, they got admitted to the hospital in isolation. They were there for 4 days. And with that, the infections spread through 4 wards and 3 primary care clinics attached. They had 58 patient infections and 18 deaths in patients. 45 healthcare workers got infected, 0 deaths, and 17 of 28 who were in direct patient care were fully vaccinated, and all were using PPE, COVID PPE, except they used surgical masks instead of N95s. And again, thinking about duration of infectivity, one healthcare worker transmitted to their household contact 2 weeks after the disease onset. This is a case report, so this remains to be seen. But again, for healthcare workers, I think we do need to think about waning immunity to vaccine effectiveness to symptomatic and to infection just as seriously as severe disease. So then you've seen all the projections of, again, observational data, which has its limitations from different countries, and there are different effects going on here, like when Delta arrived, how long people have been vaccinating, what vaccine interval they used. Some think that is one of the things that accounts for England's high effectiveness, is that more time between your 2 doses is better. So in some, the vaccines remain in all of these countries quite robust against severe disease here, hospitalization or death. Although you can see actually in England and in Israel that there is a very small reduction in that. Nothing compared to what some of the data suggests for effectiveness for infection. So with that, we know that giving a 3rd dose increases your antibody levels by a lot. And notice that this is for Moderna. This is a half dose of Moderna, which is what the White House, I think, is what they're going to be recommending as their as the 3rd dose, not the current dose, which is 100 micrograms. So a half dose gives you a drastic increase, and this is in beta and gamma, but also protects you or gives you more antibodies to Delta as well. And the Pfizer, they have similar data. So that's what we know. And so the vaccine bottom line are that high neutralizing antibodies are a good correlate of immunity. The vaccine effectiveness wanes for symptomatic infection a lot more than for severe infection. And this is supported by actually the 6-month follow-up data from the original Pfizer randomized trial from last year. When you look out, we know that the vaccine effectiveness is decreasing, even in a randomized trial setting. Also, I think there is some data from mixed data with the caveats and observational data. There's mechanistic data, as we talked about with the antibodies, and there's the modeling data. So a 3rd dose at 6 to 8 months does increase the antibodies, and then we haven't talked about the avidity and the T cell response for the variants to higher levels of protection. But I think the challenge here is, this is where a lot of the controversy is right now. There's no published clinical data on the 3rd dose strategy, okay? So Israel and Germany have already started this, so we will have some clinical data very soon. But I cannot tell you that the Barnstable outbreak or the Singapore cluster or hospital outbreaks are gonna look different because of a third shot. Nobody knows the answer to that right now, and that's where some of the controversy is. And it's possible that there are other strategies that would be better for immunity. So we know that infection plus one dose of mRNA is very robust. And so, you know, it could be, if you're not going to get sick, and if you're not going to get severely sick, if you're, you know, 20 years old and healthy, that a year from now we'll look back and think that, you know, having an upper respiratory infection from SARS-CoV-2, maybe that's better. Third dose, maybe it's better once they update it to the variant which Pfizer has started manufacturing and is testing a Delta variant updated mRNA vaccine. Whether that's really necessary, given the current ones boost your antibody levels 11 times, we don't know yet. And then, of course, the heterologous mix and match approach to vaccination. So with that, the most important thing is vaccine uptake. Vaccination efficacy needs to be, when vaccination efficacy is higher than the rate, it's much more effective to get more people vaccinated in the outcome of transmission. And so we really need to pivot from obsessing over the antibody levels in individuals here to, as a system, what are we doing to make vaccination default in our messaging, in our recommendations, in our clinic processes? This is last mile work. This is individual conversations with people that trust you, who you're their physician, and you're taking the time to have these hard conversations. And then, of course, providing incentives or requirements is another way to increase those rates. And of course, expanding the number of people who can get it, for example, children, which is likely to be reviewed in September. I'll say for the body of work, Dr. Brewer at UNC has done just an amazing job and has devoted his career to how we communicate around vaccination. So if you're looking for a place to go to get more resources on this, he's a great, his body of work is great, and the CDC and many other people have good information on this. So the key questions, I think, when you hear all this discourse, scientific discourse is great. I think it's, but it can be hard for our patients, even ourselves, to filter through all of it. And I think when you hear the sort of controversies, you need to think about where people are coming from. Is what are they saying is the purpose of the vaccine? What data do you accept as a surrogate endpoint? Because we don't have the clinical data. I will tell you the pediatric mRNA vaccine trials are going to be reviewed based on the surrogate endpoint. So if you don't accept the surrogate endpoint, then hopefully they may have additional clinical data, but I think the primary outcomes are going to be surrogate endpoints. That is an important consideration if we fully reject surrogate endpoints. And then you got to think about whether people are focused on the individual benefit or the societal benefit, and then what other tools should be used in addition to vaccines, and could there be harm of the booster messaging increasing vaccine hesitancy? And then finally, of course, is what is our role in the global vaccine rollout to provide more equity, as this is ultimately in our best interest. So let's move to some special populations for the last 5 minutes, and then we'll have time for some questions. So pregnancy increases the risk of severe COVID. COVID increases the risk of pregnancy complications and adverse birth outcomes. COVID vaccines are safe and effective in pregnancy. The V-Safe data, this is thanks to a lot of physicians and healthcare workers who actually signed up and reported their data before there was an official recommendation for this to show that, that there was no increased risk of spontaneous abortion or other negative pregnancy outcomes from these mRNA vaccines. And so the most recent update, again, trying to expand who will get vaccination, the number of people getting vaccination. Pregnancy is a key time to bring more people, to get more people vaccinated. Now, immunocompromised. So when you look at this data in different buckets, There's some variability. In general, CKD and hemodialysis respond still very well to the vaccines. We know diabetes, we know pregnancy, all those conditions respond very well to the vaccines. Specific T and B cell immunosuppressive therapies, including organ transplant, advanced HIV or AIDS, and then cancer are areas where the vaccines do not work as well. Again, based on these surrogate outcomes, the third dose has shown that you can increase the antibody levels significantly to what we consider protective based on the correlates of immunity. So with that, though, you can increase from a very poor vaccine response to an okay vaccine response. But again, the take-home message is that this is still not enough to abandon the 3 C's and masking. But from this, we see that actually the third dose seems to be tolerated well and is very similar to the second dose as far as side effects. So the side effect profile does not seem to keep going up. So the current recommendations, at least 28 days after the second dose, if you have active cancer treatment, organ transplant, immunosuppressive therapy, then you should receive a third dose of the vaccine. But again, even with that, we don't know who has responded enough. And so when you're around immunocompromised people like healthcare workers, and it's really important to really focus on the additional factors. All right, finally, adolescents, and then I think I'll finish on time. 3 slides left. So this is the adolescent data. The main vaccine adverse effect is myocarditis. It's definitely there. In adolescents, it has caused hospitalizations, but not deaths. It's mostly a phenomenon of adolescent men after their second dose, within about a week of their second dose. And what you can see here, though, is that I think the benefits in really all of these different age groups, even if myocarditis is being underreported or sampled, if you want to be very conservative and you doubled this, you're not going to get anywhere near the benefits. And this MMWR data is pre-Delta. So all of these numbers go up with Delta, making the risk-benefit of vaccination in adolescents look even better. And finally, COVID in children. So what do we know? Delta, it seems to be infecting more children, but not causing more serious infections. So the number of children hospitalized is going up, but the number needing hospitalization compared to previous strains or variants does not look different. And in general, somewhere between, depending on how case ascertainment was done, somewhere between 0.2 and 2% of pediatric cases require hospitalization, and death remains very rare, thank goodness. Now, people worry about long COVID, which has a difficult, is still hard to define, but 4%, and this is the best from a UK study that was a test negative. So this compared children who had a symptom, tested positive versus negative. That's a great study method when we're dealing with this. So you have a comparison of other URIs. And at 28 days, 4% had a symptom versus 1% for other URIs. 2% did have a symptom out to 56 days with these, including the loss of smell being one of the predominant ones that lasted in a very small group. So in general, children are already showing us what it's like for the majority of infections to be more of the upper respiratory tract because of their early innate antiviral immune response in their airways. But we also know that that is not enough without vaccination, other measures, as we're seeing, even with a 2% rate or less of hospitalization, this can overwhelm our pediatric hospitals as well. So importantly, we have no studies on Delta in schools yet. The previous alpha studies suggest that school was a low risk for secondary transmission with reasonable measures, but I am concerned about Delta, given I think it's hard for the general public and us to really wrap our minds around such an infectious virus in an unvaccinated population and the potential for exponential growth. So last 3 slides, all pandemics end on the road we're on the road to being an endemic virus where we've separated the risk of being a case from dying. But in the meantime, as our health systems are overwhelmed, we really need all of the public health measures we can as far as focusing on the 3 C's plus, I say, meaning the 3 C's plus masking. Nothing's changed from Delta in the sense that we know household contacts, dining, bars, transportation are all high-risk areas where transmission occurs. And I expect precautions in place until there's a much better global vaccine plan. And so this was a slide I made 6 months ago, actually, on the talk, thinking about what we would need in March 2021. So I think it's still holds. This is pre-Delta projections, but we still need better masks for prolonged time indoors. Cloth masks are really I don't think are ideal. Rapid regular testing, 2 times a week, 1 time a week, depends on the scenario, but Abbott by next now is great, but it's not cheap enough and not widespread enough. We need faster vaccine rollout, updated vaccines for variants. That may mean boosters. That may be actually a change in the vaccine antigen. And then effective, accessible oral treatment. We have the talk this afternoon on monoclonal antibodies, the best outpatient therapy, not oral. Please attend that. Please get that for your patients. The bullets here are ivermectin does not work. No reason to prescribe that. There is interest for high-risk people. There's data. Look up the data on inhaled budesonide for high-risk people. And now the fluvoxamine data is looking better. Please review the data carefully. There's no official recommendation to be using those. So in the meantime, we're going to vaccinate, ventilate, mask, test, and distance. And so my bottom line, since you guys asked me what my take is on what a booster is, I would say we should prioritize immunocompromised people, older people, whether it's 60, 65, healthcare workers, and people who got the J&J. We should do that now. We should focus on vaccine uptake now. We need to be getting out there, mobile clinics to middle and high schools, get places of worship, review the pediatric data as soon as possible. And then I think an additional boost to immunity seems inevitable at some point for at least these populations. But whether that comes from a 3rd dose, an updated vaccine, or breakthrough infection remains to be determined. And we'll know more from Israel and Germany. And global vaccine equity is really not humanitarian aid because it really protects us all from variants. And with that, vaccinations are an act of love. And despite all of the intensity of the pandemic, if a child, a puppy, and some sunshine don't bring you some joy, then then all hope is really lost. So thank you, guys.
Thank you, Parker. So that was awesome. And Warren, your presentation also awesome. The bad news is we don't actually have time for questions. It's the hour, and we really do like to finish on time since this cuts into people's workday. But the good news is you both addressed a lot of the questions that were raised in advance. So thank you very much for doing that. Gosh, I hate to end without questions. We've got a whole bunch of good ones, but I just think we have to respect people's time.
Can we record the questions? I can try to.
Yeah, you know what? They are in the Q&A list, so we can hold on to that and we can respond, and we can send an email out to folks with the responses.
Maybe we can find a way to respond to frequently asked questions.
Okay, that sounds good. We will do all of them, but there's some that are quite good. Nancy has them and I have, so I think it would be great to do that. Thank you all for this. We'll see you tonight at 6. Many of you to talk about antibodies. Nancy, I'll let you close.
Well, I just wanted to say, wow, those were great presentations. I learned so much. I always do from both of you. This should be recorded, and you can refer to your friends who were unable to attend to watch the recording. And I'm hoping more updates to follow. So thank you, everybody. Bye-bye.